And so I'll start with this case. And so this was a 65-year-old female. She's got no history of refractive surgery and has a history of long-term monovision RGP contact lens wear, and she loves it. So distance in the right eye, left eye, near targeted for about a minus 1.5 in her contacts. And she's a moderate myope, but does have two bucks of cyl in each eye and has real cataracts, and importantly dilates well. And she's a motivated patient. She's really hoping for freedom from glasses and an opportunity to emulate what she achieves in contact lenses. And so most of her imaging was unremarkable, clean OCT macula, OCT Arnithel, unremarkable. But what drew my attention was on her Pennicam, she's got 3 to 3.5 bucks of with the rule cyl in both eyes. And so, when we think about LAL, we, kind of the conservative cutoff is it can correct about up to approximately 2 diopters of astigmatism through light treatments. Although I've pushed it before, and I think most of us would agree that you can get more of that than more than 2 diopters through adjustments. But 3.5 bucks of corneal cyl is more than I feel comfortable with just using the LAL. And so in this case, and I have some questions laid in here, but I think I'll maybe ask them of the group after the case. I'll just kind of go through the case here first. So in this case, I did a femtosecond astigmatic keratotomy, or AK, plus LAL. And I did that AK at the time of surgery to kind of dampen some of that cyl to make her more functional prior to the adjustment process, but also allow us to kind of fully correct that astigmatism. And so our plan was we'd wait at least 6 weeks for adjustments. I kind of approached this patient like a post-refractive patient where we kind of let that cornea settle down before we try and start the adjustment process. Then, of course, also wait for a stable refraction. And I discussed with this patient, like I do with most, that because we targeted plano at the gate, that you're for sure going to need your readers prior to adjustments. And then, of course, reminded them of the UV protective eyewear and the kind of the adjustment process. And so waiting about this was actually 6 weeks post-operative. She felt like distance was good, but she was ready for some better near vision. In her dominant eye, she was relatively happy, 20/25, and then 20/40 plus in her non-dominant eye, which is attributable to some residual cyl there. So she was like a plus 75, minus 75 in the right eye. But importantly, she was correctable to a 20/15, and she was happy with that 20/15. One thing that, when I'm adjusting a patient, and I perform my own refractions at one site, and then I also work with an optometrist at another site. When I'm doing the refractions, one thing I like to do, in addition to having them, target a line of vision, is asking them, do you like that vision? Kind of chasing image quality in addition to, chasing the 20/20 or 20/15 line. And she liked the image quality. And so that's why I felt good about this initial target. So we targeted plano in the right eye, minus 75 on the left. And she came back for her second adjustment 2 weeks later, was really happy with how her near eye turned out in her left eye. She was 20/25 plus in J1. She ended up a little bit more myopic than we were targeting, but she was super happy. But she felt like things in the right eye were still a little fuzzy, even though she was 20/20 minus 3 uncorrected. And it turned out she had some residual cyl there. So we performed another adjustment in the right eye targeting plano. And she ended up doing super, super well. Ended up 20/15 in her dominant eye, 20/25 minus in J1 in her non-dominant eye with a target of -1 sphere. And so, of course, when the patients come back like this, especially when they're, a history of monovision contact lens wear, we, move to lock-in. And so the questions I would have is two, I think. Why not do a toric lens in this case? And so maybe that's a question you guys want to ask, or I have an answer myself.
So, I mean, for me, I look at that as an LAL all day, and obviously we're here to talk about the LAL, but you could do a toric. I think in our clinic, it's going to be mostly financially driven. LALs are a little more expensive, torics a little bit cheaper. I mean, a toric, I don't know off the top of my head exactly what the percentage is, but they can rotate. And a high cyl case like that, the smaller the rotation, the bigger the impact there's going to be. So you really want to be dead on axis. And then you lose the ability to customize. I mean, the LAL in theory is a monofocal lens, but I think calling it a monofocal lens is really doing it a disservice because it does have that extra negative spherical aberration that can broaden the depth of focus. and you have the ability to broaden the depth of focus with the light adjustment. So you don't have that with a toric. So if you end up at -1 with a toric, a standard monofocal toric, you're not going to be 20/25. You're going to be 20/30 or 20/40. You're going to be much more
Mhm.
compromised at distance. Anybody else have any thoughts on that?
Yeah, I'm with you completely, Nick. Just how it broadens that depth of focus and how you can get just as good of near without sacrificing as much distance. So, in the patient's left eye, they ended up at a -1. And originally with their monovision, you were mentioning how it was like a -150. So ended up at a less nearsighted target, but with better distance, and still really good near vision. So overall, just an awesome outcome. I love the Lagos ones for monovision patients just because of that better depth perception. I feel like they do a lot better at computer too for like extended periods of time and just the improved distance vision and enhanced distance vision.
No,
What
and
about
I
you, Nancy? Any
agree.
thoughts?
No,
Yeah.
I agree. I think the fact that this was a previous successful monovision patient, this is like a home run for LAL patients. You've got the customization that you can do postoperatively, and it's just a win-win across the board.
I want to use this as
Yeah.
a reminder too for everybody watching. Put questions into the chat. I mean, we want this to be interactive as much as possible. So use that chat and let's get involved. Tanner, I got a question for you.
Yeah.
With it was a RGP wear. How long were they wearing RGPs for? How many years, decades?
Decades.
Okay.
And so to answer my own question, why not toric here? This will kind of tie in the answer to your question. Um, if this patient came in, they were, high SIL, no history of monovision contact lens wear, and they just wanted really good distance vision, I think toric's a very, great option here. But whenever somebody is a monovision contact lens wearer, I always try and grab or push, reach toward LAL because as you already alluded to in your own answers, I think we know where somebody's near vision should be, but I think it's really hard to measure how much depth of focus somebody's natural lens has, even when they have a little bit of a cataract. And so, as Jessica mentioned, this patient ended up -1 when they previously wearing a -1.5 contact. And I think sometimes people want, we think we know where they're going to be near, but it's so nice to have that adjustable piece with the LAL. So they can kind of really fine tune that near eye. And then to your point, Nick, I feel like when patients come in with a history of RGP wear, they're never out of contacts as much as we want them to be. And I think it's really hard to ask somebody who's been wearing RGP contact lenses to have them not wear them for, 1 to 2 months, best case scenario. And that's another reason why I love LAL in these patients because, you can kind of overcome the less than ideal measurements you get in these patients because, as I mentioned, they're never out of their contacts as long as we want them to be. And I don't remember the specifics of how long this patient had worn RGPs, but I'm guessing it was 20 to 25 years, probably longer.
Yeah, it's a long time. I mean, in our practice, and there's no real cut line on how long you need to be out, but it's a general guideline, one week per decade of wear is kind of how we do
Right.
it. But even that is a bit of an educated guess. I mean, I've had patients where their cornea continues to change. And even, a lot of our patients have been in contacts or hard contacts for 30, 40 years, when in reality, it's maybe closer to 60 or 70 years. Or, they're just inaccurate with what they're telling us. So it's an educated guess on a poor metric anyways. So for these patients in particular, I always set the expectation that we may need to delay the treatments. We're not really restricted on a certain timeline here. We can always delay, and delay is for the best. We can push off to let your cornea continue to change. And if it does, it's kind of like golfing, right? I use that analogy all the time where the ball is moving around on the green. Let it come to a rest. You may be on a really wonky green and the ball's moving around constantly. Let it come to a rest. So yeah, great case. I love that. Another question for you, Tanner. With the AKs, when you dial in the AKs as your calculations, are you targeting zero astigmatism or are you trying to leave a little bit left?
I'm not targeting zero astigmatism, so I'm not overly aggressive, knowing that we'll adjust some. I like to, and this is probably influenced by Vance. I like to just do one AK, just preserving the option for having. I think it's easier to make a LASIK flap if for some reason you need to do that down the road if you only perform one AK. So I'm not typically targeting, zero astigmatism with a single AK.
Yeah, that can get kind of aggressive. I mean, we usually do. We'll try to target, basically cut the SIL in half. So like for somebody like this
Hmm.
with a 3 or 3.5, if we can leave them with a buck or a buck and a half, that's kind of ideal. That's well
Yeah,
within
I
the range
agree.
of the LAL, and then you got enough room to go up and down. And again, with this patient with the RGP, where you might have to go up or down, so if you can preserve some of that, that's ideal and I think super advantageous. So how long did it take for this patient to get all the way to the end? Then was this? Did you delay it? I know you said I think 6 weeks
We
is
started
average.
adjustments about 6 weeks. So I didn't add any further delay than that, even though she had a history of RGP. We started at 6 weeks because whenever I do an AK at the time of cataract with these LAL patients, I typically have them come back at 6 weeks for their first adjustment visit, as opposed to, the typical 4 weeks in our practice.